This is Dr. Chahla from Midwest Orthopedics at Rush in Chicago, Illinois, presenting a technique for ramp lesion repairs using fast-fix flex. Patients with the evidence of acute disruption of the meniscocapsular junction with associated increased meniscal translation are indicated for repair of the ramp lesion, especially in the setting of an ACL tear. A probe can be used to displace the posterior medial capsule from the posterior medial meniscocapsular attachment. A ramp lesion is diagnosed if a tear or separation is present at this junction. Multiple techniques can be used to repair a ramp lesion. In this case, we will demonstrate a repair using a fast-fix flex. After bending the implant to the optimal trajectory, the delivery needle is advanced until the depth penetration limiter contacts the surface of the meniscus. Proper deployment of the implant is confirmed by tactile, auditory, and visual feedback. Next, a second implant is deployed on the capsule for a vertical mattress configuration on the meniscocapsular junction. If the meniscotibial ligament is visualized at this point, in a distal position, it can be grasped from a posterior medial portal, elevating the meniscotibial ligament. The delivery needle is then removed from the knee, pulling the free end of the suture out of the joint. The free end of the suture is pulled perpendicularly to advance the sliding knot and reduce the meniscal tear. A Novocut suture manager can be used to assist with tensioning the knot as well as cutting the sutures when optimal tension has been achieved. A slotted cannula is inserted again to stabilize the meniscus, enhance visualization, and minimize skiving of the delivery needle to ensure more accurate placement of the implants. Different degrees of bending of the needle will aid in easier placement of sutures during the repair of the ramp lesion. Multiple sutures can be placed at this point until good fixation has been achieved, both in the superior aspect of the meniscus as well as in the inferior aspect of the meniscus. At this point, the undersurface of the meniscus is probed and deemed unstable. To repair undersurface tears and reach for tissue distally on the tibia, a reverse curved device is ideal as it allows to secure the meniscotibial ligament inferiorly. The same process is repeated to deploy the implants until secure fixation is achieved on the tibial side. Final probing of the meniscus demonstrates a secure fixation with anatomical restitution of the meniscocapsular junction. Ramp lesions are very stable tears. We only protect weight bearing for only 2 weeks. They start physical therapy on day 1, working on range of motion from 0 to 90 degrees. Strength and endurance constitute the second phase of the rehabilitation. Running progression can start at 4 months, and return to sports can start at 6 months if it's an isolated injury and 9 months if it's associated with an ACL reconstruction.